Welcome to this evening's webinar on a very important topic, the crisis of malnutrition. Thank you so much for joining us this evening. I am Joanne Lilly and the Acting Head of Communications at MSF Australia, and it's my pleasure to host this evening. We have brought together two experts in the field who have deep insights on the issue of malnutrition to give us a briefing tonight. We are seeing alarming rates of malnutrition in our work at the moment. As an indication, in Sudan, of children under the age of 5 who fled violence in El Fasher with their families and who reached our facilities in Tawila in the first week of November, 70% had acute malnutrition, and malnutrition was seen in 60% of adults, with even higher rates amongst pregnant and breastfeeding women. In Gaza, we're seeing a marked increase in malnutrition, especially in children under the age of 2 years old. And in Nigeria, MSF manages 11 inpatient therapeutic feeding centers and 30 outpatient therapeutic feeding centers in the Northwest to respond to an increasing need. Yet many families do not reach us in time. We'll talk more about this with our guests. But before we get to that, I just wanted to outline the format of the evening, which is a panel discussion of about 30 minutes, followed by a Q&A of about 15 minutes. We thank you for your questions submitted on registration. These questions have informed our discussion tonight, as well as some of which we will answer in the session following the panel. Now, to introduce the panel, joining us from a nutrition project in Katsina, northern Nigeria, is Abdul Karim Hassan. With a background in nursing and midwifery, Abdul Karim works as an MSF Nutrition and Food Security Mobile Implementation Officer, which really involves providing technical and practical support to a range of projects. Please also welcome Dr. Elizabeth Ledger. Liz is a pediatric emergency medicine doctor based in the UK, and Liz has worked with MSF over the last 13 years, both as an international mobile staff member and now in the role of pediatric advisor with the medical unit. If I could ask you each to share a bit about your experience and what motivates your interest in malnutrition. Let's go to Abdul and then to Liz. Oh, just on mute, Abdul.
Hello, good evening, everyone. I'm Abdul Karim Hassan. As earlier introduced, I'm working with MSF, currently as the Mobile Implementation Officer with MSF OCP for nutrition and food security. So I am currently working with MSF to support different projects. I was motivated in the field of malnutrition because MSF has passion to impact life, especially children and women of other vulnerable population. When I started working with MSF in 2021, I started working as a nurse, and my high interest developed then because I see we receive patients who are very sick, and then we treat patients. You see complete changing in physical, emotional, and psychological changes in the patient and the caregivers. There was this phrase the caregivers used to say, I bring my child very thin, and now the child is well nourished and grow. So this is what we see when we treat a patient who is really malnourished from their admission to their discharge. So with the global changes in malnutrition we see, working with MSF also draw me to contribute with my skill and expertise to address the nutrition situation and related health issue. So this is my main motive working in the field of nutrition. Thank you.
Thanks, Abdul. So yes, I'm Liz Ledger. I'm a paediatric emergency medicine consultant from Bristol in the UK. I first worked with malnourished children in East Timor in 2006, and since then they've been a very large part of the work that I've done in the field. I worked for a year in a rural hospital in Ethiopia, where the majority of our patients had severe acute malnutrition. And there I learned firsthand the challenges and the heartbreak of working with this patient group, and also how this work can really affect healthcare workers that are stuck in what seems to be a never-ending crisis. I consolidated this experience with some years working as a research clinician with the Medical Research Council in the Gambia in their nutrition group, and then that's led me to my current position as a paediatric advisor with MSF France and where I see malnourished patients in all of the projects that I currently cover, from Afghanistan to Haiti to Nigeria. Thanks.
Thank you, Liz, and thank you, Abdul. So interesting to hear your insights, and look forward to hearing more about your work later. I really loved what you both said about how working with malnutrition is both extremely rewarding but also heartbreaking, and I think that really encapsulates what we'll be discussing tonight. Before we get to the panel discussion, I would just like to take a moment to define what malnutrition means in this webinar and for MSF. There are, of course, different types of malnutrition. MSF focuses on acute malnutrition, a type of undernutrition related to a higher short-term risk of death in children. Acutely malnourished children have severe recent loss of muscle and fat, also known as wasting, and they can also have swelling due to fluid retention in places where there should not be fluid. That's the distended belly that you often see with children with kwashiorkor, which includes other symptoms as well. To just overview quickly what acute malnutrition at MSF looks like. We've been treating malnutrition for 50 years, ever since MSF was first founded in 1971. And we have recently seen what is just frankly alarming in terms of the data and the medical data. The numbers that we're seeing that tell us the situation on the ground, sharp increases in all of our graphs. And then to give you an idea, last year, 200,000 severely malnourished children were admitted to inpatient therapeutic feeding centers, and we had about 580,000 cases in outpatient facilities. And we expect those numbers to only be higher in 2025. We're seeing these surging numbers tripling in some places. And of course, as we've described, malnutrition remains one of the most pressing, urgent and complex challenges facing the world today. So with that, we'll now get into the questions. I might ask you first, Liz, if you could just give us a little bit of detail as to how acute malnutrition develops, what happens to a child's body, and part of that, if you could cover a bit of detail on some of the causes that you're seeing for malnutrition.
Sure, thanks, Jo. So settings with food insecurity, this not only impacts the amount of food that is available for a family and for the child to eat, but also the variety. So we see smaller and smaller amounts of food that's shared between a family. We see 3 meals a day become 2, become 1, and often of the same type of food, usually some staple carbohydrate. And initially, the physical effects of this sort of daily calorie deficit for the child are seen quite slowly. So growth will slow and weight will start to fall over time. And if this takes place over a very prolonged period of time, the child also stops growing in height. We describe this as stunting. So they become very small in height for their age. A child can compensate for a really long time like this with a degree of undernutrition. And then usually what happens is we see a catalyst such as a common childhood infection, gastroenteritis, or a respiratory infection, which could be viral or bacterial, which then tips them over into an acute crisis. And we see a very rapid acceleration in weight loss, and they can go on to develop what we would classify as severe acute malnutrition, which is the most severe level of malnutrition. And this is a medical emergency, so it needs immediate intervention from a healthcare facility. So this slow progression followed by sudden acceleration, it really underscores the importance of screening programs for children and for families, and trying to identify children with moderate malnutrition and intervening before children reach this crisis moment. So severe acute malnutrition is often the thing that I'm kind of most involved in as a paediatrician. In that severe crisis, the body begins to shut down. And this is often complicated and compounded by an infection. So children stop being able to maintain their body temperature. They become very cold. They drop their blood sugar to dangerously low levels, and we need sugar in our blood to make our brain work. So they often become very sleepy, very drowsy, and if not unconscious sometimes when they present to us in our health facilities. They can have heart arrhythmias, heart failure, and they can also present with overwhelming sepsis. And so without any medical intervention, they have an extremely high risk of death at this point. So that's the acute crisis, but inadequate nutritional intake impacts a child's growth not just in terms of weight and height, it also affects their neurocognitive development. So in little children, we see that they have slow motor milestones, so slow speech milestones. They may learn to walk and clap and speak at a slower rate compared to peers who are well nourished. And it also affects their immunity. So it then makes them at increased risk of these severe infections, which can then also tip and compound their undernutrition and tip them into severe acute malnutrition. Along with that calorie intake deficit that I've just described, then there are also micronutrient deficiencies. And these are developed from reduced intake, but also eating, as I said at the beginning, this sort of same staple every day. Children need variety in their food as well as quantity. So some of the most common deficiencies that we see might be iron deficiency. Again, this can have effects on the heart, it can have effects on brain development, and it also has effects on immunity. And vitamin A is another important deficiency that we see that very commonly affects eyesight. And these consequences will go on to have long-lasting impacts throughout a child's life. So there's the immediate short-term consequences of severe acute malnutrition, the low blood sugar, the low body temperature, sepsis, but there are also increasingly, as we understand, longer-term impacts on their health outcomes. You might survive that very acute episode of severe acute malnutrition, but you remain with a raised risk of mortality throughout your childhood. You also have an increased risk of non-communicable disease, such as hypertension, cardiovascular disease, diabetes as an adult. And then there are the socioeconomic impacts that take place due to all of the effects I've just described that really we're only just beginning to understand and need much more research to look into.
That's really interesting, Liz. Thanks for sharing some of that insight. What are some of the commonest causes at the moment that you're seeing? I'm thinking about the environment that people live in. What are some of those factors that contribute to malnutrition currently?
Okay. Thank you for asking. So I think there are a wide range of factors we have been seeing to increase the rate of malnutrition and worsening the situations. Previously, we used to see the major cause as escalated conflict happening. So in area where we have a lot of conflict, you see a lot of population displacement. But currently, there are lots of more additional factors that we see. Of course, escalating conflict is also another reason which we see in Palestine, Sudan, and also insecurity in part of other different countries like in Nigeria. So these factors really push a lot of population increase, displacement. When we have population displacement, people will have to leave their homes, their lands, what they own, their properties, and starting a new life into a different environment. So these are some of the factors that really contribute to this aspect. And also, this also have a wide range effect on agricultural production. And at the end, it will lead to food insecurity, food scarcity, and food insecurity. Another factor we also see currently is increase in rate of poverty. So this is like a global challenge where we see poverty increase, devaluation of currency, economic hardship is really more difficult. So people are finding it difficult to eat, to access health care services, standard healthcare services due to poverty. So, and people are transitioning to poor dietary habit. For example, maintaining monotonous diet. A child needs to eat different variety of food, carbohydrate, protein, but because of poverty, someone, a caregiver or someone has to usually carbohydrate are a bit usually less expensive, so they tend to go for carbohydrate mostly to give to the child, at least to the child to eat. So in that aspect, the child is losing a lot of protein which he's supposed to take for normal body development. And sometimes you see someone has to sell their valuable property, maybe animals or land or other property, to be able to afford food as well. So these are some of the issues that are really leading to poor dietary practices. Also, we have inadequate health services and health practices. This is also affecting a lot of care, because when we have someone who is sick, knows that for the care to have a standard treatment it's going to cost a so amount, but you can go to try traditional treatment, which is less expensive. So this is where a lot of them tend to stay back and then do the treatment at home. But when it's become more complicated, it's not improving, they tend to present to the facility, and this is really, really very late at that period of time.
Thanks, Abdul. I'm also thinking about what we used to call the lean season. It used to be a period of time that was specified, and there was a malnutrition peak. What's happening now to this idea of the lean season or the hunger gap?
Okay, the idea of the lean season, what we are seeing, lean season is usually the period between harvest and when the food production is usually low. So normally we have the period of raining season where people go to the farm, cultivate a lot of things, and then after the harvest, there are a lot of food. People used to have a lot of food and they can eat. So usually this is usually towards the end of the year when we see a lot of cases. The cases of malnutrition also goes low because people have a lot of food now to eat. But when it goes to March, April, May, so the availability of food is really low. People have really ate what they have harvested, and then there's no money sometimes to buy. Sometimes because of insecurity, farming was difficult to do a large-scale farming. So a lot of people do not farm. So availability of food is really depleted, and there is no enough food for people to eat. So usually we used to see lean season very 1 month, 2 months. But currently, we used to see like this peak season is really increasing. From January, February, we see the number of cases increasing. There's no food at home for people to eat. So this also has increased the period of the lean season. And at the inverse, it increased the duration of the peak activity. Peak activity before we used to see 2 months, 3 months to manage patients during the peak activity period. It also coincides with the raining period where we have a lot of medical illnesses coming from malaria, diarrhea, and vomiting. So now with the increase in duration for the peak period, complicated by a lot of medical illnesses, this will increase the duration of the peak activity, and we have a lot of patients. So now we are seeing peak activity going to 5 months, 6 months, as the case may be. So these are some of the situations and challenges we see.
Yeah, and that will no doubt contribute to those much higher numbers. Liz, I'm interested in what I've understood about, we're seeing malnutrition in younger and younger children. Can you share a bit about malnutrition in under 6 months old?
In some settings, this is a patient group that's really rapidly increasing. So under 6 month malnutrition being the area where year on year we're seeing higher and higher numbers, often in our Middle Eastern and urban contexts. So the first 6 months of your life, the WHO guidance is that you should be exclusively breastfed. And there's overwhelming evidence on the benefits of human breast milk, again, for your short, medium and long-term health impacts throughout your life. But in some of the settings that we work, where we see populations affected by conflict, migration, natural disaster, where breastfeeding practices have been disrupted, and crucially, where community support systems have been dismantled, or family units separated and spread out, and we see direct impacts on exclusive breastfeeding rates. And going hand in hand with lower rates of exclusive breastfeeding, then higher and higher numbers of malnourished babies under 6 months of age. And this is a really difficult patient group to help, because there's no quick fixes. There's no quick approaches to helping kind of reunite that bond between mother and baby and re-establish exclusive breastfeeding. It absolutely can be done, but it needs extremely skilled, specifically skilled peer supporters, healthcare workers, and it often takes quite a bit of time. The key is to have a multi-pronged approach, so involving both inpatient services, but also community support. So after mothers have spent, a week or more helping re-establish lactation, re-establish exclusive breastfeeding, then that needs to be supported, confirmed, and continued in the community. And there's a lot of kind of quite complex cultural issues that can feed into whether that happens successfully or not. What we often see are mothers and babies who we admit as inpatients to a therapeutic feeding centre. They're given therapeutic milk. The underlying issues, the difficulties with breastfeeding, are not necessarily addressed. And then they're sent back out into their communities, into the same situation, without the kind of financial wherewithal to continue to provide formula feeding. Formula is given diluted, formula is not available, water is given or cow's milk is given. There may not be the sort of water and sanitation levels to support safe formula feeding. And so the next month, this mother and baby returns again malnourished. Same thing, refed, goes back to the community, returns the next month, and that will go on until they reach weaning age. But we know that those impacts, that nutrition that you receive in the first 6 months of your life, again, that will affect your risk throughout your life of many, many things, including non-communicable disease like hypertension, like cardiovascular disease, like diabetes. So yeah, it's a very difficult patient group to support, but is a real focus for MSF currently.
Thank you, Liz. Abdul, in the context of what we've discussed already, can you share with us from your perspective at ITFCs in northwestern Nigeria, what are some of the things that you are most concerned about?
Okay. So in the context of ITFCs in where I'm working and also in different countries and places, what we are most concerned about when we have see the burden of this malnutrition and having malnourished patients, we have wide range of concerns. Number one, like the immediate impact which could come up as a result of this condition. For example, high risks of increased mortality rate coming from malnourished patients because of their impaired immune function and also underlying disease condition, stunted growth, and also the risk of infection and other health-related concerns. So these are some of the immediate concerns we are really worried about. And also, we are also worried about challenges related to readmission and relapse. We bring a patient comes to the facility, we treat the patient, and the patient goes back to the community. And then the most challenging part of it is this patient goes back home and there's no food at home to eat. So it's really challenging because we just treat the moment, and this is why we are seeing a lot of patients coming as cases of relapse. After treatment, 1 month, 2 months, the patient is malnourished again, come back to the facility, we treat patient malnourished again, come back to the facility. So we are really seeing these cases, and it's really, really worrying for us. Also, we part of the long-term impact we're also worried about is the impaired cognitive function, low productivity that could affect, and also birth-related issue like low birth weight when it comes to pregnant women as well. So we also see even though we have been working for a long period of time in some projects, in some countries, we have worked for like 10 years or more in particular country. For example, in northern part of Nigeria, where we are working, we have worked for like 4 years currently. However, we continue to receive a lot of spontaneous cases who are coming with a lot of emergency signs. What is this saying? This is saying that there are a lot of patients outside, because usually we expect to receive this patient earlier when they are malnourished, when they are sick, before they get more severe and more complicated. So if we're able to identify this patient earlier and treat this patient earlier, they could be able to improve. However, we still see like half of our patients coming directly to the hospital, not going to the OTPs earlier. So they are coming with a lot of danger signs. So that is to say we have a lot of sick patients out there that we are not able to reach them. And then when they come, they are so complicated. The outcome sometimes is the prognosis is really, really not encouraging sometimes. So our concern is, how do we ensure more wider coverage? How do we get them as early as possible? This is also one of the concerns, even though with the huge number of patients. And also the high need also is something that we are worried about. The need we are seeing, the increase in the need we are seeing, and also the capacity. Sometimes the capacity does not just limit to the resources. We might have the resources, but the structural availability that we can use to function, to work, is really difficult, because sometimes we have 100 beds or 500 beds, but you may have 800 patients. So this is saying you have to manage 2 patients on the same bed. So this is also another concern for us. And also with another concern is the volume of patients and maintaining quality of care. Like I said, you may have 500 beds or 900 beds, but you may have 1,000 plus patients. So the number of patients you have is more than what you have as the capacity. So this is really worrying to give the quality of care, because everything is planned based on the HR, the medication, everything you need. And then the number of patients are many. And of course, you can't turn this patient down, because when they present to you, they are really, really in danger need. So we really have to compromise, admit 2 patients on the same bed, and then see how best we can care for this patient. So these are some of the concerns for us. Thank you.
Yeah, thank you so much. I heard recently that we have, a facility in Katsina, I think, where there are 400 beds, and we've had to increase to 900 beds. I mean, just take a moment to imagine what 900 beds look like when they are filled with children struggling with malnutrition. It's quite a dramatic context that we're living in, a dramatic time in history for this particular crisis. Abdul,
Yeah.
I'd like to discuss a bit more about a couple of those things, but for the moment, I'm really interested in, we've talked about the idea of readmissions, same children coming back because they're released home to a context, an environment where there's no food. So I think it's important to think about, the child is a patient, but the child lives in the context of a family, in the context of a community. In that wider community is likely to all of them will be struggling with nutrition, and in a context of conflict or in a context of drought potentially. Can you describe a little bit more about MSF's role in the sector with regards to malnutrition, and particularly what are we doing to respond to some of these things? What are some of the innovations that our teams are working on?
Okay, so mostly what people used to know, what we generally used to know about MSF or different organization in terms of malnutrition, treatment of malnutrition, is having a hospital and OPT or outpatient department where we patient come and we treat patient. Of course, MSF also continue to provide care for this patient, but because of the need, what MSF does is we are trying to increase the coverage to include pregnant and lactating women in this age group as part of the coverage. And also what we do is like extending the program, our capacity, just like you gave the earlier example, having 400 beds or 450 beds, but we have to quickly increase our bed capacity to 900, 2 facilities, 2 hospitals, and also increase ambulatory therapeutic feeding center, OTP, to be able to have this patient as early as possible and provide the best care that as possible as we can. So these are some of the treatment strategy we are adopting. However, we see after treatment, the patient comes back, as just like the case of relapse. So what does MSF do? MSF, we now try to do more of like, okay, we go into prevention strategy and early detection. So the prevention strategy, what we do in MSF is provision of dry foods, and also supplementary food in some of the contexts, some of the projects, depending on the context. We have places where we give food in MSF to the patient, the community, the caregivers, and sometimes we give supplementary food to support the patient, especially the vulnerable population, to in terms of the nutritional need for their growth and development. So another also very important thing MSF implemented is cash transfers. So we see that, okay, this patient coming to our facility, they are part of the most vulnerable population. So as they form, like they are part of the family, and then they are part of the community who are struggling. So we implement a strategy to give cash transfer for all those patients that comes to our facility after discharge, so that the patient can go back home at least to use that to get some food to eat, and also help them to develop themselves, also to start some small scale business. So we also see that this helps for early presentation, because when you discuss with some of these patients that comes to the facility, why are you coming late? This patient has been sick for 2 weeks. Some of them will tell you they don't have money to transport their child, so they decided to stay, trying to get money. So sometimes it's really difficult. Some of them will have to travel for 3 hours, 5 hours on foot before they arrive to our facility. So sometimes it's really, really difficult situation. So MSF will giving cash transfer to support in this type of activity. These are some of the strategy MSF is implementing. And also, we also try to implement the idea of early identification and referrals. So what we do is the caregivers, the patients that come to our facility, we educate them and train them on early detection of malnourished signs. So we give them work tips and also how to check edema, the crash cases. They go back to the community and then they check the people in the community, or if their child is sick, they check with MWAP tape to see if this child is malnourished, and then they quickly send this patient to our facility. So this will help us to early identify this patient and come as early as possible, because some of them are at home, but they may not even know that this child is malnourished or not, unless when the child is severely malnourished. This is when they come, and at this stage, it may be really difficult for us to manage. Also, one of the things we also push in MSF is advocacy. So in collaboration with the government and other organizations, we try to strengthen the continuum of care and also ensure universal access to increase the coverage, and also to enhance evidence-based practice such as exclusive breastfeeding, micronutrient supplementation, and also a sustainable food system using local food products. So these are some of the things we do in MSF.
Thank you so much, Abdul. I'll just mention, you mentioned the MUAC, so I'll just say that, just explain MUAC, that's the mid upper arm circumference piece of, it's like a tape that we use to assess malnutrition and screen for malnutrition. And we normally use that in children. It's now also being used in adults. So that's a really great, simple measure to have the community involved in screening. Now, we talked a little bit about funding, and I wanted to address the issue of how big a gap we have currently in funding after programs related to USAID have been withdrawn and shut down or downsized completely. So I would like to ask Liz maybe first, and then back to Abdul, to just explain a bit about what is the impact on those funding cuts on MSF facilities and in the wider ecosystem, noting that MSF doesn't directly take funds from government, so we're not affected in terms of funding, because thanks to wonderful supporters like yourselves, we are independently funded, but of course we do work in an aid ecosystem, and nutrition has been provided by a number of those agencies. So Liz, would you explain a bit about how this is affecting us? And this is a question that we've received quite often as well. So thanks to those supporters who've sent in questions about this. Thanks, Liz.
Yeah, so as you said, our funding is safe, but we are all interreliant on each other. You described it as an ecosystem, which is a really good way of describing it. And organizations like UNICEF, the World Food Programme, some of them have seen a roughly 50% downsizing in their staff and in their activities. And so that leaves a gap. That leaves a gap in provision to these very vulnerable populations that I think we as MSF are having to move into, and increasingly will have to move into as time progresses. It's having effects sort of very directly in terms of disruptions to the pipeline supply of therapeutic milk, but then also into project coverage, population coverage for screening programs for therapeutic feeding centres. And then there's sort of more indirect effects as well. So the effects on the Global Alliance Vaccine Implementation, Gavi. If children are not having their standard immunisation schedule, more of them will get sick of common childhood illness. More of them will get diphtheria. More of them will get pertussis. More of them will get meningitis. And I said right at the beginning about how infection is often the thing that tips a child who's just compensating, just ticking along, moderately malnourished, into then a severe crisis. And so that indirect effect, we will also see more children tipped into a serious state of malnutrition. Malaria treatment, there are huge impacts on bed nets, rollout of malaria treatment, malaria vaccine, that are predicted to have a big effect on child health, and nutrition go hand in hand.
Thank you. And Abdul, from your perspective, how are you seeing the impact of the funding cuts?
So from my perspective, what I'm seeing is that, so with this impact of funding cuts, which really affected a quite significant number of organizations, So some have completely closed, some organization have scaled down their activities. So what we see generally is we see that MSF will really have to step in to cover this gap, because as we work in an aid ecosystem, of course, the patient might go to different places when there are hospitals, availability of services, but now that there is no availability of services and MSF is there, this patient will have to come to our facilities. So we are already seeing this in different projects, and we are already seeing our number of cases increasing. So what we are really worried about is next year how it's going to be, because we have other people supporting, but now downsized or withdrawn completely. So MSF is there, and then the number of patients coming, the structure of the need, like the volume is really going to be higher compared to what we usually used to see. And then we are more worried that we cannot even anticipate or forecast this number of patients that are going to come, because previously, you used to anticipate, expect this number of patients, but now you can't anticipate because of the need, because of the growing number of patients to expect. So this is to say, in MSF, we really have to do a lot. We really have to increase our coverage to see that we are able to cover for this need.
Thank you so much. If we can just take a few moments, Liz, to hear from you a bit about what goes into running an inpatient therapeutic feeding center. We hear about it, but we don't necessarily know how intensive that treatment is. If you could just describe what's involved, and also really importantly, what is a child's chance of recovery when we respond in the right way? What can MSF's care achieve?
Yeah, so if we start at the front door, then if I get you to imagine a very, very busy, very noisy, very loud, usually very hot area space, all paediatric services, if you think when a child presents, they always have at least one caregiver with them. Well, often there's a few that come together. So you're looking out over a sea of hundreds and hundreds of people. And our staff have to look through that sea of people and identify very quickly the children that are displaying what we call danger signs. So the ones that are very significantly critically ill and need emergency, immediate stabilisation. It's a very difficult job, and they're very good at doing so. But we know that those first 24 hours from coming in the front door of our facilities is the most dangerous. That's when we see the highest rates of mortality. So we have extremely fabulous, well-trained staff who do that initial triage. And then comes the part of identifying how severely malnourished they are. Each facility is a little bit different. Abdul's touched on some of the methods that we use. The MUAC tape is a very quick and simple way for screening huge numbers of patients. So it has a green, amber, red traffic light system. It goes around the upper arm of a child and will tell you as you tighten it which area you're in. And sometimes we also do weight, and we do height, and we look at the weight for age, and that will give us an idea as well as to how malnourished these children are. And about 10 years ago, all children who were severely malnourished would be admitted. And we've already described, 900 beds. Well, back in the day, there were thousands. And I think probably all of us who've been interested to come to this seminar will think of pictures that you've seen on the news of, thousands of children admitted all at the same time. But there was a realization that actually you can be severely acutely malnourished but stable, and we call these uncomplicated severely acutely malnourished children. And actually they can be managed in the community, and this has been a big change in the way that we work over the last 10 years. So children who do not have any of the complications of malnutrition, such as low blood sugar, such as low temperature, such as signs of serious infection, and who crucially still have an appetite, they can go home with their families and have therapeutic food at home, like Plumpy Nut, which is this ready-to-use therapeutic food that we give them. And we also give some vitamins, and we give some antibiotics. And they come back and they're reviewed regularly in an outpatient setting. And then that leaves a proportion of the children in that very busy, crowded department who would have what we call complicated severe acute malnutrition. And these children are extremely sick. In a high-income setting, they would be being sent to the high-dependency unit, intensive care unit, but they are managed with great skill and expertise by our teams in the field. So the complications that they present with are some of the ones I've already described: low temperature, low blood sugar. They may have severe respiratory distress, be struggling to breathe, have need of oxygen. They may have a lot of edema, swelling throughout the body. They may have really severe skin manifestations. And they're really very, very poorly, and what they need is immediate intervention, stabilisation, and treatment. There are two main sort of types of malnutrition that we see. Just briefly, marasmic malnutrition is very, very thin, wasted children looking almost skeletal, and then kwashiorkor is this poorly understood condition that we see a lot of in certain settings and not very much in other settings, where there seem to be multiple effects on different systems in the body, on the liver, on the gut, very much on the skin. The skin seems to be peeling off. It's really distressing to see. They look like they have very severe, extensive burns, and then we see this edema. So one of the things our teams check for is pitting edema of the feet, bilateral edema. And what causes these two different types, and there's often a lot of crossover between marasmus and kwashiorkor, is not well understood. Initially, children are then admitted to our inpatient feeding centre, and as I said, those first 24 hours are the most dangerous, the most crucial. They are fed every 2 to 3 hours. They have their vital signs, their heart rate, respiratory rate, oxygen levels monitored very regularly. And those first few hours, few days, then are really about achieving stability. So trying to replace essential salts that may be missing, sodium and potassium, keeping the blood sugar maintained, keeping the temperature maintained, and starting antibiotics, which we usually give intravenously. We do daily weights, but really the weight gain is not expected at this stage. This is really about trying to replace those essential physiological processes that have gone awry. And then hopefully after somewhere between 3 to 5 to 7 days, we see children begin to maintain their temperature, begin to maintain their blood sugar, and eventually start to show signs of appetite returning. And you really do see children kind of come back to life. These children, when they're admitted, they're not playing, they're not really engaging or laughing or smiling. But as the therapeutic milk is given to them, then they do start to almost wake up. And at the point when they start developing a bit of an appetite and interest in food, then we move them to the stabilisation phase. And that's either through a different therapeutic milk called F100, or again for a ready-to-use therapeutic food. And that's the point when we start to look for weight gain. And we're interested in weight gain. Now this complicated, severe, acute malnourished patients, that they really are very complicated. And so this population now, what we see is many more chronic conditions that haven't been picked up previously. They may be children with congenital heart disease, they may be children with kidney disease, they may be children with cerebral palsy, who have then had feeding difficulties and presented. And so I've made the pathway to recovery sound very straightforward and easy, but quite frequently it isn't. If children aren't responding, then the role of the medical team looking after them is to have a think about what else might be going on. Why are they not improving? And we often find that children at this point have got tuberculosis that's been missed, or HIV, or other neurological conditions or chronic conditions that potentially we've missed. I mentioned kwashiorkor at the beginning then. These children really make all of us who work with these patients very anxious, because they will seem to be recovering, they will seem to be doing very well, and then absolutely suddenly, out of nowhere, they may deteriorate very quickly and die. And there is very little really known or understood about the physiological processes that take place in these children, because often the settings that we're working in, we don't have the full range of diagnostic, investigative facilities that we would have in another setting. So there's a lot of work that needs to be done on these kwashiorkor patients. We see a lot of them in northeast Nigeria, and operational research, I think, is a really important part of some of the work that we do as MSF. A well-run refeeding program is entirely dependent on the staff, and attention to detail, giving the night feeds regularly on time, making up the therapeutic milks to, really carefully, safely, hygienically, taking the observations, recognizing when children are deteriorating, the documentation. And actually we have excellent outcomes despite these children being the sickest children that I have seen in my clinical experience. And as I said at the beginning, absolutely would be in an intensive care unit in another setting. So we have over 90% of recovery and exit, and then we do sadly still have very high mortality rates. So it's kind of recovery or mortality, and those mortality rates can range from as little as 3 to 5% to higher in some settings, depending on rates of kwashiorkor, and depending on the kind of setting, the context, whether it's conflict, whether it's natural disaster, whether it's a more chronic, indolent issue with food security. It's enormously rewarding, though, working in a well-run malnutrition program. There is nothing better than seeing a child who looked so unwell when they first come in the door, a couple of weeks later going home fat and happy and smiling and playing again. That's when you know that they're getting better, because they start acting like children. But it can also be quite heartbreaking as well.
Thank you, Liz. Yeah, that's a really great insight, and I love how you've described the reward and how when it goes well, it goes really well, and it is wonderful to hear that children can recover, and they do often when you've described it's not complicated. Just for the last question, if I could ask you just for a literal one-line response to looking ahead to 2026, what needs to be done? What do we need to focus on next year?
I touched on operational research. I feel very strongly that in MSF, we are one of the few groups that are seeing these patient populations, that we're there, on the front line, seeing these children with kwashiorkor, with severe marasmus, and knowing that there are some real limitations in what we offer them. The therapeutic milks that we treat them with were developed in the 1980s, and a lot of the research on this patient population was done in the 1970s and 1980s. I think one of the focuses that we should have is on improving our protocols, improving our therapeutic milk, and working with academic institutions and partners to move research forwards in this area to better understand this patient population and know what works, what we could do better.
Great, thank you. And one last word from you, Abdul, before we get to the questions.
Okay, so what I see we need to do in 2026 is we should be ready, because I feel like we are going to see more and more situations. So we should be ready to face it. We should be ready to fight it.
Thank you. Thank you so much. We'll wrap up the panel now. Thank you both so very much for those incredible insights. That brings us now moving towards the Q&A for audience questions. One of the questions we've received prior to the event tonight from several people was, what can I do? And we really are very grateful for this question, because there's so much happening in the world that we do not have control of. But there is something that we can do. We can take action. We can support projects like the ones we've heard about tonight, where children and their mothers and their families can come and receive nutritional support for free. So we'll share some website URLs now and again at the end, through which you can make a donation or visit our website to find out more. Please use the Australian one, Donate Care for if you're in Australia, and if you're in New Zealand, it's Donate Support with the NZ URL. Now, before we get to the Q&A, we would love to share with you a short video from an inpatient therapeutic feeding centre in Katsina, in which you can hear from some of the mothers whose children have been treated there.
Can gida tun da muke nema a sannu akan hankali dai muna ci bakin gwargwado wanda Allah ya hore mu dan samu ci mu da ƴan yaran mu. Aka samu da safe aka ci, kuma sai rana ta yan an samu a ci, idan ba a samu ba da rana kuma sai yamma. Dalilin da na kawo yarinya ta bata da lahiya, na zo ba dan lahiya. Alamomi dai na ga tana ta fama da ƴan masassaru, kuma tana fama da yawan rama, ɗan amaye tana yi. Mu da muna tunanin ita dai daga 'yan rani wanda ake ce ma kyanda. Shi dai ne sila ka san kowane wani tana zo mai da barkwanci. Daga nan dai aka yi ta fama har dai aka kai ga zuwa nan.
Kumburi kwanan shi 5 da tashin kumburi. Sai aka yi mai maganin gargajiya. Sai na ga bai yi ba sai na ce to bari in je ko marusa.
Ta wannan wuri ko moci ba za ta iya yi ba ta moci ba ta motsawa. Amma yanzu nan da na zo gare nan wannan wuri ana ta taimakawa ai mata wannan gata tana moci har tana kuka da bakinta har tana halba kahuwanta da hannu da kanta da kahuwanta da ko duk ba ta iya yin wannan kuma gata tana bude idanuwanta komi da komi tana muna kallanta.
Ya samu sauki ina jin daɗi yau har dariya yake kuma ya sauko kan gado ne tahiya da shi nan wurera na ji daɗi.
Hope you enjoyed hearing a bit from the women who have attended that centre. We'll move on to questions now and we'll get through as many as we can in our remaining time. So firstly, one for you, Abdul. The question from a supporter is, how do you prioritise your response when multiple regions are affected?
Okay, thank you for asking. So, as MSF is independent organization, so how we do prioritize our response is we try to prioritize based on need. We look at the prevalence of malnutrition, the mortality related to malnutrition, availability of other actors, and the access as well to this community and community. So these are some of the things, and also the budget implications. Also, these are some of the things that influence MSF decision to make intervention. So when we have a lot of actors who are already there and then they are doing what the coverage is okay, so we go elsewhere where we see that there is no actors or where the need is more. So this is how we do prioritize in some of this need.
Thank you. And on to you, Liz. You mentioned breastfeeding earlier and the importance of this. Can you share a bit about what is being done to promote and support breastfeeding and encourage good nutrition for nursing mothers?
So this has been a real focus in an intersectional capacity and also a multidisciplinary capacity. So we have a new breastfeeding initiative throughout all of the sections of MSF, which is made up of paediatricians, nutritional experts, midwives, nursing, to discuss how we can promote, support and increase the visibility, the importance of this. I think historically breastfeeding wasn't seen as a particularly medical intervention or more of a sort of nice to have, maybe not a focus. We know that, vaccines prevent 4 million child deaths a year. Well, exclusive breastfeeding under 6 months is predicted to reduce deaths by 1 million a year. So it's a really significant part of child health, and so is a big focus for us. Exclusive breastfeeding the first 6 months of life will reduce hospitalizations by gastroenteritis by 1/2 and respiratory illness by 1/3. So it very much is a focus for us. We are working with academic institutions to evaluate the most recent research to see how we can implement this within our projects, what things we can do in difficult contexts to support lactation, to support mothers, also looking at community support, so looking at peer support within the communities. There is an initiative currently in Afghanistan trying to support and improve our exclusive breastfeeding rates. We see a lot of under 6 month malnutrition there, and what things we need to do to get the biggest bang for our buck, utilising the time that mothers are with us in inpatient facilities and then helping them become peer supporters as they go back to their communities on discharge.
Wonderful, thank you. A supporter question has asked Abdul, how are levels of nutrition monitored in order for a fast response to issues, thus preventing deadly malnutrition? I was just on mute, Abdul.
So what we do is when we want to monitor the nutrition situation, we maybe we want to make an intervention. We can do rapid nutrition assessment in the given community or population to see what is the prevalence of malnutrition, and also we could access data from other organizations, UNICEF, WHO, and other actors. Also, so this also will help us to make that decision. And when we are running a program as well, we do monitor our progress using the SMART survey, which is the standardized monitoring and assessment of relief and transitions. So this is a survey we do like annually to be able to see what the prevalence of malnutrition and also the mortality related to the age group related, certain age group related. So this SMART survey help us to make decision to see where we are, how far we are improving, what we need to increase, how do we need to increase in our activities and projects. So this SMART survey help us to really monitor the progress of the activity and then the situation in the community. And also we try to also integrate other components such as the food security, available food security component in the SMART survey to be able to follow the situation.
Great, thank you so much. Last question for this evening. I'm going to direct this one to you, Liz, if I may. This supporter has asked, how can a multidisciplinary approach ensure adequate maternal and neonatal nutrition, particularly in a low-resource, high-risk setting? And I'm going to chuck another one into there as well, which is related to multidisciplinary approach, and that is, do we work with dietitians?
So we know now increasingly that actually dealing with mothers and babies separately doesn't work. They are one entity, the mother-baby dyad. And so it's extremely important that when we design our services, our projects, we think of the mum and the baby staying together. And this is called a zero separation approach. It means that we work extremely closely with our midwifery colleagues, with our obstetric colleagues, and all through all steps of the journey from antenatal through to birth, through to postnatal, we try to keep mum and baby together. There's huge amounts of evidence and research showing the benefits for keeping a baby and a mum skin to skin, whether they're preterm, whether they're term, whether they're sick, whether they're not sick. And so that's been a real focus for the way that we design and implement our mother and baby services. And sort of building on that multidisciplinary approach, I described the multidisciplinary team that we've got in the breastfeeding initiative. We absolutely do work with dietitians, as I described in the complicated severe acute malnutrition. You know, there are some very specific patient groups that will have particular needs. Cardiac disease, children with renal disease, and so we work with our dietitian colleagues to help us understand the best nutritional support that they may need. We also work with physiotherapists. The children that have kwashiorkor can have horrible, as I said, it's sort of like burn type involvement of their skin, and they can get nasty contractures. So it's really important that physio is there to help reduce and prevent that. I'm trying to think of other multidisciplinary teams that we work with, but yes, very multidisciplinary.
All right, great. Thank you so much. Just a few minutes to time now. I want to thank you both so very much for joining us from the UK and from Katsina, Abdul, with your insights. I know it's very early morning for you, but very grateful for you. And thank you so much to our supporters for your interest in our work and for joining us this evening. I hope that you have learned a bit more about malnutrition and the need to respond. Thank you for your support of MSF's work. We are extremely grateful for the donations from people like yourselves who keep the work going and keep MSF independent, neutral and impartial. It is because of you that we have the expertise in communities that need medical support and the ability to expand services, add beds when we need to, and provide the care that our teams do. Thank you so much if you have already donated this evening. If not, I invite you to donate tonight using the URLs on the screen. Please be sure to donate or use Donate Care for Australia, and if you're in New Zealand, it's Donate Support. Malnutrition is an emergency that requires urgent action from all of us. Then we will continue to update on our work. Please do follow our socials and check our website for updates from all of the areas that we work. Thanks again so very much for joining us tonight. We'll follow up soon with a recording and a feedback survey in the coming days. Thank you again and good night.